Thank you, and I'm really excited to be here, physically and mentally, and share with you some highlights from an update in internal medicine graduate medical education. So it's focused on medical education research projects that have been published over the last year that apply to both teaching residents as well as teaching students, as well as a lot of what we do in medicine. And I just want to give credit to some of my collaborators. We do this systematic review of the medical education literature each year. And I'm just going to share with you some of the key highlights. So I've selected some articles out of our usual update to share with you. So over the next hour or so, I'm hoping that we become familiar with one method for assessing the quality of medical education literature. If you read medical education literature, this might be a useful tool for you to look at to see if that literature is valid. We'll review some leading publications from 2017 in the field of graduate medical education in internal medicine, and we'll have opportunities for discussion regarding some of these key publications and how they impact the things that you do. So first, I'd like to just quickly review with you how I do this with our team each year. We do a systematic review of medical education literature published in PubMed. We pull all educational studies in internal medicine, focus on residency training program. Originally, it was based on English and US and Canada studies. Over the last several years, there's been medical education research going on across the world, and it is now expanding to include all studies. That is our literature search terms. If you ever want to repeat this, I don't encourage you, just write me and I will send it to you. Just so that you're aware, last year we identified 534 studies. We reviewed 180 that we selected to meet our criteria, and then really got it down to 146 studies. Of those 146 studies, they were scored using this validity tool, which I'll review briefly, and we selected the top quartile of articles based on validity to share with our audience and write a review paper. And I'm going to share with you some of those top quartile articles. So the Mirsky tool is a medical education research study quality instrument. It was derived several years ago from a group of authors at Mayo. And it's been very helpful in helping us assess the validity of educational research. Is this a good study? Does it apply to my residents, students, teaching environment? It assesses 6 domains of quality: design, sampling, type of study, validity, data analysis, and outcomes. And the scores reliably identify areas of methodologic strengths and weaknesses. So we applied the Mirsky to the 146 studies and then selected the top quality studies from that group. I'm going to focus on 4 themes that I just pulled out to share with you today. 2 of the articles are just interesting and fun to talk about, well-done studies, and will prompt some discussion, I'm sure. 2 of the studies are in quality and patient safety. 3 of the studies are in resident, but I'd say physician and learner wellness and fatigue, and that is a really hot topic now across the world. So I chose to bring you 3 of those studies. And then we may or may not get to the clinical skill on history taking study published by Kelly Skeff, which is fascinating and really is ties right in with Back to the Bedside. But we may not get there because I hear you're a bit talkative. For each theme, we'll review 1 to 3 publications, and I'm going to stop after each theme and invite some discussion, just so that I don't share 8 articles and then invite discussion. We'll do it about every 2 articles. So let's get into our first area. So just some interesting, fun studies that I came across from last year. So the first study focuses on professionalism, or residents, learners in training, demonstrating behaviors that might be labeled as unprofessional. This study was published in the Journal of Graduate Medical Education and looked at what is the impact of an interactive workshop and a booster quiz. So if I run a workshop on professionalism, can I get our learners in the medical education arena to recognize behaviors that might be labeled as unprofessional and then to change their behaviors? So the study was done at multiple sites. It looked at residents in their 1st through 3rd years. It was a 75-minute workshop, and then they had a quiz after the workshop. The workshop was based on case-based videos around professionalism. They had large and small group discussion. They used a standardized tool and some discussion questions, and they developed some summary statements on self-monitoring for professional behaviors. The residents completed a pre and post survey and a post-workshop quiz. So to look at some of the results, on this graph, down the left-hand side are the lists of things that are classified by these authors as unprofessional behaviors in medical residence. So saying not so nice things about their emergency medicine colleagues or other colleagues in the profession, primary care providers. Maybe disparaging support staff, so saying not so nice things about their nurses, their pharmacists with whom they work. Blocking admissions or trying not to bring a person into the hospital to potentially avoid work. Turfing, maybe trying to move a patient to a different service, not theirs, and then misrepresenting test results. So it happens here too, not just, yeah. Okay, so there you have it. I was worried about that word, might not work, but so on the scale on the bottom, professional is 5 all the way to the right. So more professional is up there, less professional down there. And these are the residents' perceptions of their behaviors. Do I, as an individual, demonstrate these behaviors? And you can see in the dark is pre the workshop, and in the white is post-workshop. And so residents were more likely to reflect and recognize their own unprofessional behaviors after the workshop. So it really helps with that self-assessment of some of the things that I do may not be professional in my environment, including those things highlighted there. They also asked the residents, do you actually participate in unprofessional behavior? And again, the dark is pre the workshop, the white is post the workshop. On the y-axis is a percentage of residents reporting participation in unprofessional behaviors. And so you can see here that pre the workshop, about 40% of residents said that they disparaged or said not so nice things about their emergency medicine colleagues in medicine. After the workshop, that went up, actually. And again, maybe an enhanced recognition of those behaviors. I don't necessarily think the workshop made them less professional, we hope, but maybe a recognition of some of those behaviors. They did go down in sort of saying that they demonstrated some of those behaviors in disparaging support staff and in misrepresenting tests. So maybe some efficacy of the workshop. So limitations of this study were lack of a control group. There were more interns, first-year residents than other residents in this study, which may have skewed the results, and it's self-reported data. So implications, this video-based workshop may have modest impact on self-reported perceptions and participation in unprofessional behavior. Most importantly, it certainly seemed to lead to an important increased awareness of what a professional or unprofessional behavior is in the medical environment. So the next study I'm going to share with you is just a fun article that I pulled out. Cardiorespiratory fitness in internal medicine residents, are future physicians becoming deconditioned? I might argue this applies to faculty as well, so we can all probably learn something. This was again published in the Journal of Medical Education. This was published last February and has a fairly high Mirsky score. So their question was, what is the change in fitness, age, and physical activity when one goes into graduate medical education training? And I'm sure you can anticipate the results. It's a self-reported survey on exercise habits, height, and weight. Investigators measured waist circumference and resting heart rate at the end of noon conference. I don't know if that's an ideal time, but that's when it was. They determined fitness age by plugging it into a calculator known as a Hunt calculator, which was based on a Norwegian Nord-Trøndelag health study cohort, and it estimates VO2 mass. So it's a measure of fitness age. And so their results, so if you look at this, the analysis of exercise habits prior to and during residency and exercise habit, and they defined it as almost never or less than once a week, 2 or 3 times a week, or almost every day. You can do your own self-assessment right now where you fall in there. I'm embarrassed about where I do right now, unless it includes walking through airports. You can see here that prior to residency, of the residents interviewed, 9% of them said that they almost never exercise, and then after residency, that was up to over a third of residents almost never exercise. Not great. And you can see on the opposite end, prior to residency, a third of the residents said, I exercise almost every day. During residency, only 4% say I exercise every day. So a significant change, not unanticipated. So how does that correlate then with their health and well-being? Again, an important topic now across the world. So the mean circumference, waist circumference for men and women in this, and the mean body mass index for men and women in this study, overall it was 125 individuals. And you see that their body mass index was 25 and 21.8. More importantly, the difference between mean fitness age and mean chronologic age was 5.6 years. So residents were on average 6 years older than they should have been in fitness age. That was particularly prominent in men who were 6.8 years older than their chronologic age by fitness age. Women were 3.4. So women, you're doing better than the men. But that's a pretty startling statistic. More studies to be done, but certainly gets us thinking about exercise and health and what we're doing in our trainees. Certainly limitations to this study was a cross-sectional design. It was a single point in a time estimate. They used the Hunt to estimate VO2 max rather than actually measuring it directly. And there are definitely unique factors. It's not all about residency. This is an age, as you all know, where lots of things happen in their lives that have an impact on their ability to exercise. Implications, residents don't exercise enough, nor do faculty or probably medical students. So something for us to think about as we focus on wellness across our profession. So I'm going to stop here and let us take about a 5-minute break. And really, if you would, maybe turn to your neighbor, and I will stop you. And what surprised you about this data? And what can you do about this? How is this going to apply to what you do every day with your learners or your peers? So what surprised you, and how is it going to change anything that you do? Okay, I'm going to go on to our next section. But before we do, does anybody want to share what surprised you or how you are going to use this information in your environment?
What surprised me was the gender difference in the second study, because we have done a lot of studies, mainly with medical students and some with residents. And usually, women exercise less. And so this gender difference in favor of women surprised us.
I wonder if that's site-specific. That's so interesting. I bet that's site-specific, maybe culture-specific. That'd be fascinating to look at to get a world view. I love that comment. Other comments or questions, thoughts? Okay, I'm going to move on to our next section. I'm really excited. Now we need to do something about that. So the next section is going to look at 2 articles in the arena of quality and safety. The first one is of a lot of interest to me because I really struggle with this as a program director. So I'm fascinated in your response to this article. This was an article, again, published in the Journal of Graduate Medical Education, looking at procedural experience in medicine trainees, and does their experience, number of procedures done, ensure competence. And so the question is, how many procedures does a trainee need to be competent? And obviously this could extrapolate to many fields, not just medicine. In the United States, the American Board of Internal Medicine does not specify a minimum number of procedures to demonstrate competency. However, to assure adequate knowledge and understanding of the common procedures in internal medicine, each resident should be an active participant for each procedure 5 or more times. I love that I see eyebrows raised with the number 5, because if you needed a central line and someone told you they had done 5, you may not want to be 6. But that is historically the number that program directors have used. So good that someone's looking at this. So does clinical experience, the number of procedures done, and the year of training predict the ability to meet or to exceed minimum passing score for a procedure in a controlled setting, so in a simulated environment? So this was a synthesis of 7 studies that were done at several institutions. There were 5 academic medical centers. They did not look at all procedures. They looked at the procedures listed there specifically. And this included residents from across several specialties. They compared objective evaluations of residents at baseline in simulated performance and then before and after an educational intervention. But this is really looking at the baseline data. The residents that were involved primarily They were looking at 140 residents doing an internal jugular central line, 143 doing a subclavian central line, 94 doing lumbar puncture, 56 doing paracenteses and thoracenteses. You can see the breakdown there by PGY level. So in particular, thoracentesis is predominantly done by upper level, higher trained residents. And then the clinical experience, so the number of procedures that the residents had done coming into the simulation varied greatly from 0 to 21. So a lot of rich data that we could then see, does that predict their ability to pass this assessment? The individuals used a standardized assessment tool or checklist for the procedure to determine competency in the simulation center and trained observers. So the results. There were 588 baseline measurements of simulated procedures performed by the almost 400 unique residents. As a whole, resident performers met or exceeded the minimum passing score in simulation for only 10% of the procedures, which is extremely low and was a huge surprise to this study. On the left, this looks at the percent passing the simulation with competence and the odds ratio of passing based on the clinical experience. So as you go down the left-hand column, the number of procedures that the resident had done prior to coming into the simulation center, and then the average percent passing or meeting competence for that procedure, and then the odds ratio. And as you can see here, certainly if you had done 7 to 10, there was a 20% passing score, but there's really not a predictable pattern here, which tends to lead us to believe that experience doing procedures there's more than that just to competency. On the chart over to the right here, it looks at postgraduate year in training, and you can see here that second years had the highest percent passing score and the highest odds ratio, but still extremely low for what we would want to see in a competent resident in doing procedures. So the bottom line here, having some experience performing the procedure and not being a first-year resident increased the resident's chance of passing the simulated exam. However, passing rates were very low for everyone. They did validate it with faculty, true procedure experts who were able to pass. They did not do a comparison group with faculty that were not super trained. I think they were trying to just show that their assessment tool was reasonable. Years of experience and increasing number of procedures performed are not a predictor of competence. That doesn't mean that we know what is, but at least that is not. So the limitations in this study, the assessment presumed that achieving a minimal passing score on a checklist in a simulated situation equates to competence in performing the procedure, and that may be not a great assumption. Local experts determine the checklist, so trainees new to the system may have had a hard time with that new environment and maybe with different standards, and this study was limited to only one city in the United States. Implications, the traditional standards for setting competence based on minimal numbers needs to be questioned. And so I can't wait to hear your thoughts on that. I'll move to the next study in the quality area, and this looks at error disclosure, another hot topic across the world. So when an error is made, how do we train people to disclose that error to their patients? So this study was entitled Learning Through Experience, Influence on Formal and Informal Training on Medical Error Skills, Medical Error Disclosure Skills in Residence. Again, this was published in the Journal of Graduate Medical Education in February of 2017. So as many of you are aware, there is an increased focus on disclosure skills. It is an element of the ACGME and the ACGMI Pathways to Excellence. Medical schools and residency programs are increasingly developing curricula for error disclosure, and the Canadian Patient Safety Institute published national guidelines for error disclosure, which are excellent, in 2008. The research question of this study, have resident error disclosure skills changed over time, and do they vary among 3 different specialties? So this was a mixed method study. It was a study of error disclosure performance using standardized patients, so again, in a simulated environment. They did in-depth interviews and follow-up with the residents, which is probably the most interesting piece of this study. They had 3 cohorts of residents who participated in the standardized simulated error disclosure exercise. Their first pool was in 2005, and I'm not really sure what happened for the 7 years in between, but then they did it again in 2012 and 2013. The institution incorporated during 2009 to 13 a 3-hour error disclosure workshop into a formal half-day curriculum annually for internal medicine and once for pediatric orthopedic surgery residents. They had 2 cases. One was an inadvertent insulin overdose, and then the other one was a medication administration error when a patient had an allergy. The rating scale used by the standardized patients included assessment of explanation of the medical facts. So did the trainee go over the medical facts with the patient? Honesty and truthfulness. Empathy, demonstration of behaviors consistent with empathy. Prevention of future errors, so saying to the patient, this is what we're going to do to make sure this doesn't happen again. And then general communication skills. And this very much goes with the guideline statement, which have been published by the Canadians. So the results. Which variables predicted better overall scores? Was it training program? Was it attendance at the workshop? Was it prior experience? Was it other prior disclosure training? Or was it the study cohort? It was the study cohort. So probably trends over time. The other things were not necessarily associated with better demonstration of skills in error disclosure. And so in the interviews with the only 9 residents, they were asked, how do you learn to do error disclosure? Is it formal mechanisms or informal? And compellingly, the residents said, we really learn more from informal mechanisms, from observing and role modeling, and faculty and senior residents leading pre-disclosure briefing and team meetings to talk about what's to be said. What did they think was more impactful? The informal mechanisms and creating a supportive culture to disclose. It's not something new or questions, it's just what you do. So really the trend over time in these institutions towards that type of a culture. So the limitations, this is a single institution. The study could not objectively identify which variables or factors led to the improvement. The implications, spending more time and resources focused on those informal mechanisms is probably where an institution or a department will really move things forward. Teaching error disclosure through role modeling, pre and post disclosure meetings, and that may be more beneficial. So I'll stop here and take any comments on those 2 articles if you want to share some comments about what you see in your environment in procedure training or what you see in error disclosure and what you're doing about that here.
Stephanie, some time ago when we didn't have the word safety in our hospitals, we had a rule for procedures. I don't know if you have a similar one in the US. The rule was that the first one you look at, the second you do, and the third you teach. So this was the rule in Brazil years ago. So right now I'm a program director in this brand new, let's say, new in age hospital. We do have a public hospital and a private. We're separate systems here in Brazil. But our public hospital have the same rules, the accreditation, the quality, and everything. So I don't know if you have anything to share with us. So how hard is it today to have these numbers and these curves? Because just to point out something, the private hospital, the radiology does all the thoracentesis and paracentesis and everything. So I have to schedule my resident with the interventional radiologist so he can go there and do that. So it would be nice to hear from you. How do you deal with that in the US? Because we are having a transition in Brazil, but it's very different from like 20 years ago or 15 years ago when we were training, and right now this new reality of quality, which is very good and important for our patients, which are the objective of everything we're doing. But how do you train people in this environment? It's so different from the old one.
It's a wonderful question, and as a program director for the past 20 years, I've struggled with this, and I used to be very cavalier about procedures, and I was also trained in the see one, do one, teach one model. We definitely made a shift to the interventional radiology. And I used to laugh at my residents, I'm not proud of this, and say, why are you sending them to interventional radiology for a paracentesis? We can do that. And then I really thought about it, and I said, if that was my family member, I would want them to go to interventional radiology. Send them. We have, across the country in the United States, actually made another shift because interventional radiology has now become overwhelmed with these procedures. And many of our institutions, both private and university-associated institutions, are adopting procedure teams run by hospitalists. In fact, in several environments, the hospitalists are actually going into interventional radiology and doing the procedures for the interventional radiologists now, because that's the way that it's worked from them. So that is more of how we're doing the procedures. Training is still a challenge. My residents, I still am very uncomfortable with when do I say that they're competent. And so the checklist approach has become part of what we do, and now we rely on our expert procedure teams. I would say in the medicine residency programs across the United States, 25 to 50% of programs now have dedicated procedure teams and procedure trained faculty, and they are the ones that teach the procedures using the checklists. But it's very slow. I just looked at my second year residents, and very few of them are signed off as competent, except for in central lines and maybe, well, definitely paracenteses. They do a lot of those. But they don't, many of them don't get to thoracenteses anymore, just because of the depth of the training. It's a huge challenge. I think we have also acknowledged they may not need to. And really, our credentialing board has really acknowledged that, and there is no requirement now for procedure training. So we focus on what they need to do to provide the care, the central lines in the middle of the night, and the lumbar punctures and paracenteses. But it's an evolving thing from a care and from a training standpoint.
Concerning the first study, maybe the learning curve for each one of these procedures is different.
Yes.
So I think we need more studies to address this question.
Yeah.
How many central lines, how many lumbar punctures, how many thoracenteses, because they combine things
Yes.
that maybe cannot be combined.
I think it's a wonderful point, and I think you're absolutely right. It is different, and it's probably not just numbers. It's probably including informed consent, including error disclosure, including the rapport with the patient, and then those checklists of competency, and people are going to develop at different times. It takes an enormous amount of effort to really put that curriculum together. And so that's a challenge to, I think, everyone across the world, and I don't yet know anyone that has it perfectly right yet. It's a great point.
What's your interpretation for the decrease observed, the decrease of competence with the growing experience?
Yeah. I suspect it is because it is so tied to the checklists, because we have seen the same thing as we've rolled out a similar curriculum, that when my second year residents are working with my proceduralists, they get really good, and then 7 months later they have slipped back because they're not constantly being coached by someone who's using our standardized checklists, and I think that's probably what they were seeing there.
Mm-hmm. Thank you.
I don't know, but I think in the second study, the data are not so strong to support the implication to abandon the formal training.
Yeah, it's sad, right? For how many of you are formal medical educators? Yeah, it's kind of sad, right? When we prove that a curriculum doesn't really impact something. Yeah, so I think it certainly doesn't hurt, hopefully. I'm about to talk about a curriculum that looks like it doesn't really hurt. It certainly doesn't hurt, but it needs to be augmented significantly. Yes, it's not enough alone. Yeah, which I think is important. I'm going to move on to the last set of studies that we're going to look at, which is around resident and trainee wellness. And again, I think this goes to faculty wellness, and again, something that we're struggling with across the world. So the first study that I'm going to share from last year is restoration of resident sleep and wellness with block scheduling. And many programs have moved, internal medicine training programs have moved to a concept of block scheduling, which in the United States now means you do X number of weeks inpatient type activities and then X number of weeks outpatient type activities to try and develop some balance and not always have our trainees in the inpatient environment. Some people do 4 weeks inpatient, 1 week outpatient. Some people do 3 and 1. My program does 2 and 2. Lots of different pictures, but that's what block scheduling refers to. And this was published in the Journal of Medical Education. So does block scheduling have a positive impact on resident sleep and wellness compared to the traditional format where someone might do many inpatient blocks in a row? So what they did, this was done at one study. It's a cross-sectional study. It was done in Oregon. It's a large urban academic medical center. They have almost 100 internal medicine residents. And what they really did here was look at their schedule of 3 weeks in the ICU and 1 week in ambulatory, rather than their old schedule of 4 weeks in the ICU. They compared them to the rotating residents from anesthesia and other fields where they were doing the traditional 4 week in the ICU. And they looked at several different features. So some of the measures that they looked at were sleep, and all 3 of the studies that I'm about to talk about used wrist actigraphy, which is basically your Fitbit, if you will. So they put Fitbits on all of the residents. They wore them for the 4 weeks. It measured total sleep time, sleep latency, sleep efficiency. So how did they sleep? They also measured sleepiness and perceived stress at different time points during the study. So this first slide on the y-axis is total sleep time. Wouldn't we all love to be here? I'm down here right now. And then here's the medical ICU first 3 weeks. Here's the ambulatory week. And here are those residents that did 4 weeks in the ICU. And as you can see here, in the MICU, the mean total sleep time was 6.48 hours. 84% of residents, while they were in the ICU, said that they slept less than 7 hours per day. And 7 is turning out to be a really critical point. They slept a little bit over half an hour more if they were on a day shift than on an overnight call or an extended shift. On their ambulatory block, as you can see here, they got more sleep, and their mean total sleep time was almost at 7. Which again becomes an important number. And unfortunately, while better, still 55% of trainees slept less than 7 hours a day. I'm interested. Disclosure. How many people in here sleep on average less than 7 hours a day? Yeah, okay. That was about 80% of this room. So this does not only apply to trainees. If you looked over time at sleepiness, stress, and total sleep time, some very important patterns emerge. And this is actually finally a piece of data to support the block scheduling that we're using. And I like this because it supported what I did in my program when I didn't have the evidence. So if you look at, this is total sleep time over the time in the ICU, and we're going to focus on this side. You can see that their total sleep time was 6 point something, and then as soon as they got on ambulatory, it went up. For those that stayed in the ICU, their total sleep time stayed lower. If you look at stress, you can see that their stress in the ICU was going up. We've all lived that. And then as soon as they went on ambulatory, their perceived stress went down. And in the ICU, going into that 4th week, if you were 4 weeks in the ICU, the stress really hits a peak. And then if you look at sleepiness, they were sleepier, and then they went into the ambulatory block and their sleepiness decreased. And if you stayed in the ICU, your sleep peaks at that 4th week in the ICU. So I think we all knew that this was happening, but it's really data to support what we observe every day. So total sleep time was significantly less while in the ICU versus ambulatory. Wellness measures worsened over time while in the ICU and improved to baseline after a week of ambulatory rotation. And total sleep time was less than 7 hours on average for all residents, which these authors were surprised about, particularly given the duty hour changes in the United States during the time of this study. Limitations: this was a single institution, single setting. It did not assess the 4-week group in the very first week. It didn't assess factors that influence sleep patterns, and there are limits to using a Fitbit to measure all of this. Implications: the ACGME rules address acute sleep deprivation rather than chronic sleep deprivation, and this is real nice demonstration that we need to think about the chronic. Duty hour restrictions may not improve sleep or provide adequate recovery time, because everybody was surprised by this given how strict the duty hour regulations were during this time. Cumulative sleep debt may contribute to a decline in wellness, with sleepiness and stress going up. And block scheduling may be an opportunity to help improve these measures. So having an awareness of the potential of sleep problems to affect resident wellness is important, however you decide to do that. And I would say faculty wellness as well. The second study that I'm going to look at looked at sleep and alertness in medical. This is a terrible thing to talk about before lunch, I guess. But sleep and alertness in medical interns and residents, and looked at the role of longer work hours. And this was done by some of the leading authors currently in this arena, Kevin Volpe and Lisa Bellini. And this was published in Sleep. So they asked the question, what are the differences in sleep duration and alertness between medical interns who work extended overnight shifts, which you may be aware we just brought back into the United States when we had taken them out for interns, or rarely working extended overnight shifts. So what they did was they combined 2 randomized control studies. They did an analysis of the control group with no mandatory naps and the standard schedule. And then they looked at 2 or 4 week blocks on either inpatient internal medicine or inpatient oncology rotations at a couple of different sites. What they measured was, again, your Fitbit, looking at sleep time and activity, and then they also measured sleepiness. And they did a 3-minute psychomotor vigilance test, alertness, if you will. So just to summarize, they had 224 participants. They collected a ton of data, and they analyzed a lot of data from the alertness test and from sleepiness. And so they looked at sleep at night, 9 p.m. to 9 a.m. when people are supposed to be sleeping, although I'm sure nobody in here sleeps till 9. They looked at the shift type. So before a regular shift, before you're on a long shift, when you're on a long shift, before you have a day off, which turns out residents sleep a lot, actually, the day before they take a day off, which is awesome because they get ready for their day off, and then across all shifts. And you can see here what the sleep times were during those different types of shifts, in particular on call, very little sleep during that 9 p.m. to 9 a time. Their time during the sleep on the same kinds of shifts really showed that mostly when you are post-call, so after an overnight shift, you sleep more during the day, which makes sense because you're fatigued. But the total sleep time varied tremendously by shift. Again, really just showing you a demonstration of how much their sleep-wake cycle gets completely messed up by their long shifts. And that showed a little bit better in this, which, not to look at the details, but if you look at each of these as a curve for an individual person that might be going through different shifts, they have really altered sleep-wake cycles and disturbance from these altered cycles. If you look at napping after they do a long shift or during the shift, some proportion of residents get naps. So this was the proportion of individuals that got no sleep during a very lengthy shift, less than 2 hours, 2 to 4 hours, or greater than 4 hours. More on-call sleep means less napping. And then if you look at their total hours of sleep obtained, those who actually got some sleep while they were in the hospital, so if a program requires a nap, they sleep better the next day and they get more total sleep, which is where the recommendation from the ACGME came from to require naps for overnight calls. So average total sleep time was 7 hours for senior residents versus 6.9 for interns. Again, less than that 7-hour mark. And they definitely had increased total sleep on their days off. They get the least sleep on their on-call days, as you can see here. And I'm sorry, when they're looking at that alertness response, this was their alertness response, which is decreased on their on-call shifts. And this shows a beautiful pattern for sleep deprivation and their alertness. So more alert is higher, and this is the prior 12-hour sleep duration. So if they have no sleep, they're less alert, and it goes up over time. And as you can see, 7 hours becomes fairly critical. That's really where you see it plateau. So 7 is not just a number pulled out of the air. It's a number that truly is validated. So interns sleep less during extended shifts. Sleep loss is only recuperated with napping if you were able to sleep greater than 4 hours during your extended shift. Total sleep time of less than 7 hours for interns, greater than 7 hours for residents. Alertness, number of attentional lapses, and subjective sleepiness were worse after on-call nights, were most severe in those who did not sleep at all. Again, there are limitations to this study, but the implications are extended shifts result in average total sleep time of less than 7 hours. Sleep deficit, which is a really important thing for us to be paying attention to, requires additional time to compensate, and that compensation is important. This poses a risk for physician and patient safety, and sleep periods in the preceding 12 hours have beneficial effects. There's definitely a need for mitigation strategies to prevent negative consequences. So I'm going to do one last study, which is a study looking at, can you build a resilience curriculum? So if people are stressed, if people are getting burned out, can you do something for your medical students, your residents, or even your faculty to build their resilience and have them be more aware? So this study was published in Academic Psychiatry, and it was looking at a curriculum called the SMARTER curriculum, and it's a prospective cohort of this resilience curriculum for residents, and it was created by residents. So what is the feasibility of implementing a resident-led resilience curriculum? What are the risk and resilience factors associated with resident burnout? And how does it change over 6 months in a residency training program? How can wearable, again, Fitbits, help understand resident health behaviors? So this was done at one center. It looked at interns only, first-year residents, and they put together a training program that they called SMART 3RP. Stress management, if you ever do this, I would not name it so long. Stress management and resiliency training, relaxation, response, resiliency program. It was developed with residents, and it was focused on teaching them relaxation responses, teaching them stress awareness and coping behaviors for when they got stressed in the clinical environment, and providing a positive perspective taking and meaning finding in what they do every day. We run a very similar curriculum at our own program, and we've seen very similar results. They looked at a burnout inventory, and they chose the validated Maslow. They looked at risk factors using perceived stress scale, health questionnaire, and a functional assessment of chronic illness looking at fatigue and worry. They looked at several different resilience factors. They enrolled 88% of the interns in this study. 91% completed the baseline questionnaires. They were less successful in completion of follow-up questionnaires. So what did they find? They found that there was an increase over time in emotional exhaustion, and the Maslow Burnout Inventory looks at emotional exhaustion, but it also looks at depersonalization and then really finding meaning in what you do. And so they saw increases in depersonalization over that first year in training, increases in emotional exhaustion, increases in depression, and increases in fatigue, which are not unexpected in residency training. Not good, but not unexpected. They saw a decrease in optimism, which is depressing. And they saw no change at all in perceived stress, worry, sense of personal accomplishment, coping skills, self-efficacy, mindfulness, or empathic perspective taking. So I guess the good news is that they didn't see those things go down. The bad news is that they did not see them go up. One might wonder if what they did helped people create the resilience to at least keep stable in these areas. 96% of the people wore the health tracker. There was no difference in sleep or activity, and it was not related to burnout on the surveys. Limitations to this study: it was a single center, but it has been, many centers have now done similar studies and found very similar results. And the implications are a resident-led resiliency curriculum, or I would suggest any resiliency curriculum, is feasible. It may be counterproductive. I don't really think it's counterproductive. What I think it does is increase individuals' awareness. As soon as we started running our curriculum, we had a significant increase in burnout, and I don't think the curriculum hurt the residents, but I think they were much more aware, and we've created a culture where they feel much more comfortable reporting that they're burned out and stressed. So I don't think it truly was counterproductive, but measures may go up. Intern burnout risk and resilience factors and behavior may be more influenced by external environmental factors than internal states, which I think we're finding for faculty as well. We certainly need a lot more controlled studies of things to mitigate burnout, and a different approach to measuring burnout and its impact is necessary. So I'm going to stop there and take any final comments or questions about this last set of questions on this important topic of trainee burnout and wellness.
Stephanie, we do have in Brazil a law. It's a federal law about, that says how many hours the residents should be on the services and everything. This is an old law, but it's not obeyed by most programs. So this is the reality in Brazil. I know that Professor Maria do Patrocínio had time to do this right here. In my hostel, they do, but I probably in maybe 70 or 80% of the services, they don't obey that. It's a 60-hour rule for a week.
Yeah.
It's less than the U.S.
Yes.
So we do know that you have a rule on hours, but is there a recommendation? I've been through SCGME website a few times, but is there a recommendation when you talk about the block scheduling,
Yeah.
or is that still on a service initiative? So
It has so far been a service initiative. Part of the reason, so my program moved to block scheduling actually early on, but we did it for different reasons. For our residents to have their continuity clinic experience, it was getting really disrupted between inpatient experience and trying to have outpatient experiences and running back and forth. So we separated those. And the ACGME does mandate that you separate those, which pushes you to wind up trying to come up with a block solution. We view the impact that it's had on our residents on stress and fatigue as an unintended positive consequence, and my residents would never go back. They really love our schedule. Across the country, there is so much variability, but if anybody does a literature search on block scheduling, we're really finding very positive things associated with it. The ACGME doesn't mandate it as of yet, and it has primarily been in internal medicine, but it is quickly creeping into other specialties. So at my own institution, pediatrics went to a block schedule 3 years ago, neurology went to a block schedule this year, and psychiatry just told me they're going to a block schedule, and my fellowships are going to block schedules. So I think you will see and hear a lot more about this. And to us, we started ours in the ICU because I kept seeing anecdotally the fatigue that the interns and residents were hitting in that third week, which correlates so beautifully with this data. And so that's why we use a 2-week block schedule. Ours do not do something different every 2 weeks. They go into their inpatient for 2 weeks, then they go to an ambulatory block, then they come back to their inpatient environment, same team, same unit, same nursing staff, because that team part is really important. So we still have maintained our 4 weeks sort of schedule. We've just kind of split it, which is interesting and unusual.
Just one of the reasons I ask you is that when I was a resident, we had an atypical, not typical schedule. I had in my first year 10 months of inpatient
Yes.
service, but we had an outpatient clinic for each resident,
Yes.
2 hours on like Mondays or in the Wednesdays or Tuesdays and Thursdays. So, and that was very interesting because you had your outpatients. It was your outpatient
Yep.
setting. There was a senior physician supervising you, but you had your schedule for all the residency. So it was very interesting from the standpoint that you're training the resident to work like horizontally with patients and everything. So we lose that when you block
Yes.
everything up. So do you have any insight in this regard? Because I think there's a loss when you
Yes.
block. It's good for the stress and for the well-being, but I think there's a loss with the follow-up of patients.
Please.
Could you please talk about the ambulatory schedule you
Yeah.
have? Because, for my opinion, my residence is much more stressed in the ambulatory set than
Yes.
in ICU.
That's yes. Well, and maybe for practitioners as well, right? I think that is one of the downsides of these block schedules. Is we probably not yet labeled it properly, but for lack of a better label, that ownership and relationship longitudinally, there has been a negative impact on that. There's no doubt. That's part of why we went to this every 2-week block schedule, because then they are at least in their own clinic every 2 weeks, and they can continue to follow a panel of patients. Because many programs are using 4-week blocks and then a week of ambulatory and then 4-week block, and patients don't get sick every 5th week. So that's been really disrupted. That has been one of the significant negative downsides to block scheduling. Our residents, so when we actually assess it, and multiple studies have shown this, that the stress, and it is maybe specific to the United States, although I know it's also a program that I work with in the Middle East has seen something similar. They are more stressed in the inpatient environment than any ambulatory or consults may be slightly different. And it often has to do with the stress of the duty hours, because they are trying to get out. The program director is walking around saying, you need to leave. But we haven't, we've done a lot of work compression into shorter hours, and it has put an enormous amount of stress on our residents. I think that's a systematic issue and something that we need to fix from an education standpoint. We've done that to the residents. For anybody old like me, it is much more stressful to be a resident now than it was, in the good old days, because they're trying to do all of this and have families and get out and all of that. So we don't see that in the ambulatory environment, that they're as stressed, but it's because I think we have better work hours, that they're not fighting again quite as much. So our residents will, across the United States, in general, a resident will probably see 5 to 8 patients in a 4-hour block. Mm-hmm. And it's very program dependent, but that's a good average. Yeah.
My comment is about sleep deprivation. I think that is one of the major problems of medical students and residents nowadays. And it's not only do what they do when they are in the hospital, but also what
Yes.
they do when they are on their free time. I was very impressed because the residents of the last study sleep 7 hours per day. Here in Brazil, they sleep less time. And when we apply the Epworth scale here, both in medical students and residents, the mean values are something like 11 or 12.
So
And
we
in
should
the
stop complaining?
And in the first study, it was 6 after it's much lower than here in Brazil. So it's a very complex issue.
It's
because
very complex.
like Bonamigo said, here there is a limitation of 60 hours per week. But they are allowed to work in other hospitals when are not working as residents.
Yeah.
So the total time is about 80 hours per week, like the United States.
So very similar.
But here they have higher scores when we apply the Epworth sleepiness scale. So it's more complex this. The time they spend in using their smartphones is increasing. There are other
Yeah.
Netflix maybe.
It's very complex, and as you said, we have several studies in surgery and also in medicine from last year that showed that when we decrease duty hours, their sleep does not go up. They just find them, in fact, it goes down in at least one large surgery study. How much sleep they got went down, but how much time they got busy doing other activities out of the hospital went up. So reducing work hours didn't increase sleep. And it is complex. It's also about sleep habits and other things.
But it's very important. And in our study with medical students, almost 50% of medical students that had an Epworth scale of higher than 11
That's phenomenal.
said that their sleep was good, and said that they had enough time to sleep, so they are not aware of sleep deprivation.
Yeah.
This is, I think, one major issue here.
So a lot for the world to work on. Well, I think I'll stop there, and thank you all very much.